Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Tiffany Hensley McBain. Today's episode features content from an educational program titled Contemporary Management of HIV. During this podcast, Dr. Joseph Eron from the University of North Carolina in Chapel Hill and Dr. Jason Halperin from Tulane University and CrescentCare in New Orleans discuss management of complex HIV cases, including switching antiretroviral therapy in a patient with potential underlying resistance and initiating antiretroviral therapy in a patient with obesity. For more information on Dr. Eron and Dr. Halperin, and for a link to the full online educational program, including downloadable slides specific to today's discussion, please visit the show notes for this episode. Now let's get started and hear what Dr. Halperin has to say about switching ART in a patient with an unknown or incomplete resistance history.
I'm going to be talking about switching ART in a patient with potential underlying drug resistance, and then we're going to talk about the issues around weight gain. So looking at this patient case 2, I see this a lot. I mean, here's a 26-year-old woman. She might be a little younger than I see most of the time because she was diagnosed 10 years ago. So at 16, she was quite young, but with a CD4 count of 34 and a viral load of 430,000 in the setting of pneumocystis. She responded very well to pneumocystis treatment, which is great. She was started on efavirenz FTC TDF, co-formulated at that time with good response. She was on and off therapy with occasional elevations in her HIV-1 RNA. She then dropped out of care. There was no resistance testing. She stopped, restarted her ART with a boosted PI, darunavir-based regimen. She recently moved to town. She doesn't have her records. At some point, she must have been started on a single tablet regimen, the darunavir, cobicistat, FTC, TAF. And now she's doing quite well. She's virally suppressed, less than 20. Her T cells are TU90, but that's good from a nadir of 34. So what are our reasons to consider an ART switch? And you can see on the left, we have our appropriate reasons, and our right are inappropriate. So for appropriate, it's to simplify regimens. And if we could change someone to a single tablet regimen who is not on one, that really would be a goal. We want to do everything in our power to enhance tolerability and decrease toxicity because that's the right thing to do, and ensuring adherence. We want to mitigate any drug-drug interactions, eliminate the food and fluid requirements, and always we should be taking into consideration pregnancy. I think that we're going to have more of a discussion, and I'm really looking forward to when the guidelines may weigh in on this, of when we might choose a change because of cost. But when would it not be appropriate? Because a regimen is new. I hear this often, oh, this is brand new. Do you think I should switch to it? No, if you're really doing well and tolerating your medication well, might not be the best time, would just be because a regimen is new. And we would not want to switch a drug to reduce costs if there is the potential of toxicity or intolerance. So here's what the DHHS guidelines say. For drug resistance, we always have to look at the ART history and possible virologic failure. We should review each genotypic test result. So all the ones done in the past, we have to look at them together to determine one's resistance. If earlier resistance was uncertain, we want to maintain that suppression. So we want to always go, and you'll see this come up over and over again, from a high barrier to a high barrier. We really don't want to move from a high barrier to a low barrier of resistance. Within class switches usually maintain suppression, and caution when moving from a boosted PI to another class, especially if it's lower resistance. And just like Joe said, I think we all, as good clinicians, do this. We consult an expert. Oftentimes in this field, that's a friend we have because we've done this work with colleagues so long, but getting that input is important. For safety, we want to review the ART history. Always take into account that HLA B5701 if you're going to use a bacavir. Consider drug-drug interactions. And comorbidity, I always remind my fellows about the Hep B co-infection. And we're going to really be talking about this a lot as we move into the injectable era with cabotegravir and rilpivirine. Cardiovascular risk, renal function, bone mineral density, and I mentioned pregnancy, all things that we should be considering. So this question came up, so I'm so happy that we could jump into this now, which is a question of when to use the proviral HIV genotype, also known as the archive. So this is a really nice option for us because it's a DNA genotype that we can use when someone is fully virally suppressed. But we have to be careful because it's less sensitive than looking at a cumulative RNA genotypes. It's actually less sensitive of an RNA genotype itself. So we would only use this when we have to in the setting of someone who's undetectable and you want to see if you could tease out any of the resistance patterns. Importantly, the concordance is wide from 25 to 84%. So this is kind of the key. If it's there, it's really there. If it's not there, you have to be concerned that it might be there. And the best example from that is the study 1824, another study I bring up to my fellows because the archive missed the M184VI mutation, which is our most common mutation when someone is on ART and developed resistance. And it was only picked up 48% of the time, 40 out of 84. So really, I always say, if you're going to use an archive, potentially presume that someone has an M184V or I, and likely presume anything that you might be concerned for. So what the guidelines say, it's the archive proviral DNA genotype should only be considered for patients with suppressed viral loads, with particularly if complex or semi-complex pre-existing resistance. And I really like this quote: for individuals who have experienced multiple prior failures, prolonged history of prior ARV regimen, and for whom genotypic test results are not available, it may be appropriate to utilize. So it's that may be appropriate. And again, I'm going to highlight here in red, the proviral genotyping may miss some or even all pre-existing mutations. So now we actually used the archive, and you did pull out that M184V, so that's good, as well as the K103N mutation. Not surprising in this young woman who was on and off therapy when using efavirenz. So now I want to walk through how you would think through this case and what you would recommend for her. So here is the question. We have, she's suppressed. She's suppressed on a boosted PI regimen, a single tablet. What do our phase 3 studies show? And you could look, we have great data on phase 3 studies for those who are suppressed switching to a single tablet regimen. But only 2 of them, and you could see them in red, was resistance permitted. So all the others were kind of, in a way, I call them our perfect patients. They were on a regimen, they were suppressed, no concern for resistance, and then they were switched. So you really have to think about the generalizability of our study. So in this case, we do have 2 studies with patients with resistance permitted. And let's go through some of the data that exists. Now, it is very exciting that I get to sit here with Dr. Eron, who actually published Switchmark in the Lancet. And I'm going to tell you that this is one of the mandated articles in our journal club. So my fellows must read this article, and it comes up every week in clinic. This was such a nice study for us to learn from. So in this study, there were 700 participants who were randomized. They were virologically suppressed, who were either continued on the boosted PI, lopinavir-ritonavir regimen, or switched to raltegravir, of course, at that time, our newer integrase regimen. And when you look at this study, 1/3 had already demonstrated virologic failure. And at week 24, there were more virologic failures, 16% versus 9%. So 16% in the raltegravir arm, 9% in the boosted P arm. And that was outside the predetermined non-inferiority definition, prompting early cessation of the study. Most of the switch failures, so those who failed, were due to underlying resistance. So important. We move from a higher barrier to a lower barrier, we saw what happened. This is great for a real world study. Of course, the lipid parameters really improved, which was also part of the study. But in this case, we really learned a lot from SwitchMark. So having you here, please.
I don't have anything to add. I think you described it perfectly, Jason. I think, in retrospect, I mean, when it was being developed, we really thought it was going to be a great idea. We did try to blind the study, which maybe was a mistake. It made it more complicated. But either way, it really showed the difference between or how a boosted PI, which we all know has a very high barrier, can kind of cover up or clean up or mop up kind of residual resistance that, at least in this study, raltegravir was not able to do. So the differences weren't huge, but they did not, unfortunately, it did not meet the non-inferiority margin, and it was a failed study.
It's so important for us to learn from studies that fail as well. I mean, and
yeah.
Okay, so what does DHH say? Patients with prior drug resistance can be switched to a new regimen based on their ARV history and resistant testing results. And I'm going to jump in now to really look at two studies, 380-4030 and then the Dawning study, which I actually think will be really helpful for this patient. Don't forget, she's a patient with a known M184V K103N moving from a boosted PI. So here in the 380-4030 study, really nice look at comparing patients that were suppressed on dolutegravir and then were switched to bictegravir. Of course, half were switched, half were maintained on dolutegravir. And you can see there on the left, the virologic outcomes are very, very similar, non-inferiority, and the pre-existing resistance to NRTIs was 25% in the bictegravir and 24% in the dolutegravir arm. And here we could actually look at which resistance was most common. And I really want you to look at that right-hand side, the M184V side, and you could see over 85% in the dolutegravir, 87% in the bictegravir. So this data suggests switching one high resistance barrier drug, so you're moving from dolutegravir, high barrier of resistance, may be effective in patients with viral suppression, even in the setting of underlying resistance. Now, with this slide up, I do want to point out there's very small numbers in that left-hand side. The K65R are greater than 3 TAMs, and Dr. Aboud at Croy did a great poster on this, and there were only 3 in the bictegravir arm, 2 in the dolutegravir arm that had a K65R. So I wouldn't want anyone to walk away from this slide thinking that high level of resistance one could use a single tablet regimen. But with an M184V, and I'm going to show you further data with dolutegravir, I'm feeling very confident in our second generation integrase inhibitors. Between class switching. So that's now the other question. We have a lovely young woman on a boosted PI. Can we switch her to an integrase inhibitor? Well, we know from SwitchMark, we've got to be very careful about that, especially when we moved from boosted lopinavir/ritonavir to raltegravir. Well, what would happen if we switch someone to one of the higher barrier integrase regimens? And that's where the Dawning study is so elucidative for us. Here we have patients that they already failed an NNRTI. So they've had first-line failure. And I should say this is an international study. Efavirenz is the first-line regimen in patients in most of the rest of the world. So a patient that failed their first line is often going to fail an NNRTI. So an NNRTI plus 2 NRTI failure, and they were either switched to dolutegravir or boosted lopinavir/ritonavir plus 2 NRTIs. And you could see here in the attention to treat analysis, 84% in the dolutegravir arm, 70% in the boosted lopinavir/ritonavir arm achieve viral suppression. So that did demonstrate superiority for dolutegravir. Very exciting. I will note, though, that 2 patients in the dolutegravir arm when they developed virologic failure, did develop resistance. And not only did they develop resistance, they already had at baseline a NRTI resistance, but these two patients did develop integrase resistance. So I would say if you're switching someone, even though most, 84% in this study, are going to do just fine, you still need to keep a close eye on this patient. I think that my takeaway from these two virologic failures with integrase resistance is you're still, especially when you're switching someone, I don't just switch them and see them 6 months later. You really need to keep that close eye. So let's look here on the left-hand side. I don't know if you can see my pointer here, but left-hand side is all the M184V or I patients. And you can see they do very well on a dolutegravir regimen. So here we have really strong data showing that a dolutegravir-based regimen with 2 NRTIs, I feel very confident in the setting of an M184V or I. One caveat, which is, since this is an international study, 40% were on zidovudine 3TC. So maybe you think about that a little, and hopefully with further data to come, we could feel even more confident, even though I say that this dawning data is really, really reassuring, especially, don't forget, we're switching someone who's suppressed. These patients were failing therapy. So I think that makes a difference as well. So let's jump into the poll question. I'll ask Dr. Eron the same thing to go through his thoughts, but which of the following treatment options would you recommend for this patient? Joe, why don't you take it away? What are your thoughts?
Yeah, so I would pick C, and I'll say why. I mean, one is I think you showed convincingly that a second generation integrase plus 2 nucleosides would be the right therapy for this woman. She's already suppressed. There's some question perhaps that could she have other mutations? It's an archive genotype. She did have failure. She wasn't the best adherent person on her efavirenz, FTC, TDF. So I would pick B or C, and I just pick C because of it's a single tablet, so it's more convenient. I think raltegravir is a great drug. It was a great drug. It saved a lot of lives, but I think in this setting you'd want to use it twice daily. It doesn't have the same barrier to resistance. And then I know there are some data, in mostly European data, for people who have an archived M184V who got dolutegravir 3TC and stayed suppressed, but it's not randomized data. I would not. I don't think you can really justify that. And then the thing about dolutegravir rilpivirine, while the package insert says as long as you don't have resistance to dolutegravir or rilpivirine, it's okay. The thing to remember is the study itself that was done, SWORD, which was a tremendous study, very effective combination. People that had virologic failure of any kind were not entered into that study. People might have had, transmitted 103N, but you could argue for dolutegravir rilpivirine. I wouldn't, say that's wrong, but I would follow that person very carefully. And same with cabotegravir rilpivirine. I would be careful because of a failure on efavirenz. There may be other NNRTI mutations that you can't see on the archive genotype. So I'd pick C. If you wanted to pick B, that's great. And I think F would be okay, but I would follow the person really carefully. And they'd have to take it with food. They'd have to show me, tell me when they eat and all that stuff. So that's what I would do there.
I couldn't agree more. And for G, I would love to see this clinical trial. That would be very interesting. But I think you're right with the current data. We kind of discussed this at length. What feels the most comfortable in terms of switching, and the take-home points are: patients with prior drug resistance can be switched to a new regimen based on their ARV history and resistance testing results. Pro-viral DNA genotyping could be considered for individuals but you really have to remember it could miss some, if not all, pre-existing mutations. And if earlier resistance is uncertain, only consider switch if new regimen is likely to maintain suppression of resistant virus. Move always from that high barrier to another high barrier. So this is the first line ART in a patient with obesity. And I don't think I get a single question more now than this. So let's jump into the case. And then I wish at the end of this I could give you some good answers. I think there's a lot of answers. There's a lot of good questions that still need answers. So we have a 39-year-old woman. She was seen in our STD clinic, diagnosed with chlamydia as well as HIV-1. Upon evaluation, she's healthy. She's a young woman. You prefer to start a single, simple therapy, plan to do everything. She says she plans to do everything possible not to become pregnant. Her CD4 count is 150, so slightly, it's on the lower side with an RNA of 634,000. Her genotype is wild type. Her BMI is 30, and you can see here everything else is normal or negative, and importantly, the hepatitis B is negative. So what are the first line regimens? We have our, we really want to think about what's most effective and most well tolerated. And for the DHHS, that's bictegravir co-formulated with FTC-TAF, dolutegravir, bacavir 3TC, only if someone has HLA-B5701 negative. Your dolutegravir in your DHHS guidelines can be with TAF or TDF. Raltegravir is still part of the DHHS guidelines, but the newest now is a co-formulated dolutegravir 3TC, so our first 2-drug regimen. But really important, you could not start that in a patient with an RNA greater than 500,000. In this woman, she has 600,000. You would want to think about hepatitis B. You cannot use dolutegravir 3TC in the setting of a co-infection of hepatitis B. And much like we talked about in the last case, you really wouldn't want to start this 2-drug regimen if any transmitted resistance occurs, any NRTI transmitted resistance. ISUSA, they have fully TAF only for its tenofovir-based regimen, bictegravir or dolutegravir, but they also allow dolutegravir, bacavir 3TC if your HLA-B5701 is negative. And I'll bring it to Joe. Which ART regimen would you consider for this patient?
And I don't want to sound like a broken record, but you're going to show us some data, but I still think that our best therapies are the second generation integrase inhibitors. And I would pick A or B. I don't think G is wrong in certain situations, but not in this one, as you point out. So I would pick A or B, and I would probably go with A just because I think one pill is probably better than 2.
The bictegravir FTC-TAF, which I think has become our most common regimen, and I think it is it's a single tablet regimen that's incredibly well tolerated. And we're going to jump into some of the data of some possible adverse effects of the second generation integrase. But when I think about what is best tolerated, it's clearly our second generation integrase right now. So, I know we don't have much time, and I do want to get to Q&As. So, our standard of care is rapid start. So, would you do anything differently?
Nope. I would not. I would try to get this person on therapy absolutely as fast as possible. That's the right way to go.
Yeah, I would agree. But in a way, I think I would be starting almost the second generation in all of these patients. And the Soprano data has made me much more comfortable of starting dolutegravir, even though she did say, planning to become pregnant, that's a harder question. It's probably a whole nother webinar that we can have. Okay, so she would start on dolutegravir FTC-TAF. I think that's a very appropriate choice. Good tolerance, viral suppression, but she did present with progressive weight gain over the next 18 months. Her BMI increased to 35. despite our counseling about diet and exercise. So what do we know about the second generation integrase inhibitors? And the ADVANCE study is a really nice study to answer this. And this is the ADVANCE study is done in South Africa. And what I loved about it is they looked at dolutegravir with TAF compared to dolutegravir with TDF. And then they also, of course, because as I mentioned, first-line therapy in most of the rest of the world is still an NNRTI-based efavirenz. And it was naive patients that were randomized to those three arms. And looking here, even though it wasn't superior, though we do have superior data, overall for integrase inhibitors, there was definitely a trend to superiority, 85%, 84%. So the TDF versus TAF dolutegravir, you could still see very, very effective. The efavirenz at 79%. Before we move on, though, I do want to point out, look how quickly people suppressed with the integrase inhibitors. And with our knowing that U equals U is fact, undetectable is equals untransmittable is scientific fact, it's hard to argue against a regimen where, by 4 weeks, almost everyone is suppressed. 80%. That is, really shows the efficacy of this regimen. But we're talking about weight gain, so let's jump into the weight gain. So if you see here on the left for men, dolutegravir plus FTC TAF had a 5 kilogram increase, and then dolutegravir TDF had a 4 kilogram, and the baseline with efavirenz is 1 kilogram weight gain. So definitely more weight gain in the second generation integrase. But in women, it's even more significant and quite concerning. You have a 10 kilogram increase with dolutegravir TAF, and the 5 kilogram increase with dolutegravir TDF. So this is also showing that there is some synergy between the TAF and dolutegravir. Also, as many of you know from the IES presentation, Dr. Greisel did a really nice presentation on how quickly people metabolize their efavirenz. So the higher metabolizers, medium and lower, the high metabolizers, if they got that efavirenz out of their body, they seem to be the same as the integrase. So if they were a low metabolizer or medium metabolizer, that was really where the protective effect was. So it's important to think it adds more questions as opposed to answers, but it looks like efavirenz might have some protective components to weight gain. Looking here, I'm sure many of you read this. This was Dr. Sachs's fantastic article in CID. He looked at the clinical trial participants. Interestingly, you'll see all the way on the left, even in the earlier clinical trials, it seems once a regimen is better tolerated, we're seeing weight gain overall, but once you move on to the right-hand side to the newer regimens, you're really seeing an even more significant increase in weight gain. Interestingly, last, I do want to point out that 380-1490 study, because I get this question all the time. Is there a difference between bictegravir and dolutegravir? And the studies are really not bearing it out. So though I think we're trying desperately to find what would be the best regimen, I wouldn't say we're seeing any difference between those second generation integrase inhibitors. And when you look at the multivariate analysis from the randomized clinical trials, you'll see again, same thing, INSTI, higher weight gain compared to PIs or NNRTIs. And then you could see that bictegravir, dolutegravir really is the integrase inhibitors that are leading this. Elbapixant, cobicistat less, even though some people think that's because cobicistat can lead to some nausea or GI side effects. So, that tolerability still becomes a question. But I think the harder question, and we'll get to it, Joe, I love your opinion, is this whole question of TAF, TDF, are we coming around to think that TAF should not be, that we shouldn't maybe poo-poo TDF as quickly? I'd love to get your opinion on that, but let's just go through this quickly. You could see that, unquestionably, there's a difference in the NRTIs of TAF, and you're still seeing between the integrase inhibitors compared to NNRTIs or PIs a real difference. And I think what was teased out in the Sachs article that was so concerning is you're not only seeing a BMI increase, you're seeing an increase in ASCVD score, and 50% shifted from an ASCVD score where you would not start a statin to recommending starting a statin. So really considering the cardiovascular impacts of this increased BMI. What do the guidelines say? New guidelines recognize weight gain as a common and severe adverse event associated with ART. Weight gain has been associated with initiation of ART and subsequent viral suppression. The increase appears greater with INSTIs than with other drug classes. And, we didn't present the study here, but, you're seeing an increase with doravirine compared to efavirenz as well. So, I don't think we have yet that a silver bullet regimen. And I know a lot of people keep asking me, is there something that we would do in terms of ART regimen currently? Further clarification on distribution of weight gain associated with cardiometabolic risk, and if it is reversible upon the discontinuation of the offending agent. I just wanted to know one other thing, and I'm sorry, I missed it here, but I do want to bring back to the Sachs article also pointed out, which I think should be noted, that CD4 count less than 200 was a higher risk, RNA greater than 100,000, and black versus non-black was a higher risk. And when we think about points of taking into consideration all aspects of our patients, we need to really think about weight gain. And female versus male, and especially female African-American, had the highest risk in the clinical trials, and then those who were overweight versus normal. So, these are big issues, and they're really, really concerning, though I don't have many answers. So the outcomes case, and now I get to throw it to you, Joe, 35-year-old woman, BMI 31. She's concerned. She's on bictegravir, TAF, FTC, co-formulated. She's tolerating it very well. Would you recommend anything, and where do you go from here?
Yeah, I think that there's a question in the chat that is really asking really the same thing. And I don't think there are any data to really guide us. I think you've already said that. I think that the difference between TDF and TAF is not so much that TAF promotes weight gain. I think it's the other way around. I think TDF actually has some impact on either appetite or bloating, or there's some effect. But that's just my opinion. There are obviously observational data that show kind of going off TDF to TAF, you get a bump in weight really within like a 6-week to 3-month period, and then it kind of levels off. And we know from some of our comparative studies that, for example, in the Gemini study that compared dolutegravir 3TC with dolutegravir TDF FTC, the weight change was actually a little bit more with dolutegravir 3TC than dolutegravir TDF FTC. So I think, but I do think that the integrase inhibitors are associated with weight gain. I think it's not just return to health, especially in women more than men, and people of African origin versus those that aren't. And I think I try to prepare my patients from day one. Whatever you're doing right now, you're going to have to do something more if you don't want to gain weight when you start these drugs. And I think switching to TDF or switching to efavirenz just doesn't really make sense. I think it's not the best thing for the patient, I don't think so. But it's tough. I don't have a good answer. There is an ACTG study that will be starting very soon, looking at people that have gained at least, I can't remember now if it's 5 or 10%. I think it's 10% body weight. Actually, on a integrase, they will either stay on their integrase, switch to doravirine, TAF, an FTC or doravirine TDF FTC or 3TC, and to see if they lose weight. I've tried switching. I haven't had a great effect. I don't know, maybe you have. You probably see more patients than I do.
No, I know the ACDG study is coming. I'm very excited for it. You know, what's interesting is I have switched a few people, and when I do, it seems to encourage further diet and exercise.
Yeah, I know. I heard that today.
I don't think it's the switch. I think it's me saying, I hear you.
Yeah.
Let's do something, but you really bring on some diet and exercise, and that. Yeah. I'm seeing that.
Yeah. No, I think that makes sense. And also, if people kind of blame their medicine, right? If this medicine then I think you have an adherence risk. I don't think there's any problem with taking, I mean, you know, the Tango data are so strong. I mean, you could say, okay, well, we'll go from, in this lady, dolutegravir FTC TAF to dolutegravir 3TC. Let's see what happens. I'm hearing you. Or you might say, you know, we know there are data from Drive Shift that darunavir is certainly a safe shift. I don't want to say that 10 times fast. Safe shift. You know, that is a reasonable approach. I think, and if it helps people kind of buy into taking their therapy and maybe doing other things they need to lose weight, then maybe that makes sense.
Our take-home points quickly. Weight gain has been associated with initiation of ART and subsequent viral suppression. Greater weight gain with INSTIs compared to other drug classes have been reported, more pronounced in women versus men. Greater weight increase has also been reported with TAF versus TDF, as well as doravirine versus efavirenz. The consequence of weight gain remain uncertain, and it's unknown if weight gain is reversible upon stopping or switching the suspected offending ARV.
Yeah, no, I think that's great. So Jason, I assume that in terms of your kind of first for treatment naive people, you haven't steered away from either dolutegravir or bictegravir based therapy. Is that?
So that's correct. I mean, you know, at our clinic, we really have the standard of care being rapid start now, and we're using only dolutegravir or bictegravir. We're also only using a TAF-based regimen. I have had a few providers start pushing me on, you know, at what point would I say that's a discussion for the patient and bring up, hey, we have TDF versus TAF. There's limited differences. One with potentially more renal impact, definitely for bone mineral density, but more weight gain synergistically.
Yeah.
I think that,
I mean, if you had an African-American woman, a Black woman, you know, in her 20s, you know, without any renal dysfunction, you know, I mean, you could certainly do dolutegravir 3TC and see.
Yeah.
And if those other caveats, like they don't have Hep C, they don't have resistance, it's a little harder to do rapid start with dolutegravir 3TC. I mean, it's not impossible, but it's certainly more cumbersome. You know, because you have to switch if you end up with a positive Hep B or there's some transmitted nucleoside resistance. So
I agree with that. There is, I know that there's a trial right now looking at rapid start with dolutegravir 3TC. I'm a little concerned that you would be starting a regimen and then having to broaden. I don't really love that. You know, have someone come back and say, oops, I got to go more broad. But, you know, I do think it brings up a good question, a Truvada dolutegravir, you know, TDF FTC dolutegravir. Is it something we should consider? And we are not as a standard of care at our clinic, but I do think.
Yeah, we're not either. Yeah.
Yeah. I was wondering if.
Yeah. No, I haven't switched. I haven't changed doing that. I am very careful, as I mentioned, about weight and talking about what people eat and what they exercise. And I also think that, you know, there is some probably catabolic nature to having very active HIV infection, and we're kind of shutting that down. So there is some, kind of natural weight gain with HIV treatment. But there was that very nice study, now I'm mixing up whether it's virtual COI or virtual AIDS 2020, where they looked at Kaiser, right? And they showed weight gain compared with infected versus uninfected people. And, people that were underweight, people with HIV gained a little bit more than people who were living without HIV. In the overweight group, they were kind of paralleled at both groups. But in the obese group, in the people not living without HIV, their weight was pretty stable. But people with HIV who got on treatment, their weight also went up. It may be slightly, not quite as quickly, but there's certainly something about the medicine. So we seem like we don't talk about too much else in weight gain right now, but it really
is something that I have brought in to talk about. You're newly diagnosed, that you've been fighting this virus, even if you were not aware that your body's fighting this virus. The ART is going to work so quickly. We're likely going to suppress you in 4 weeks. This is a great time to start an exercise plan.
Yeah. Good point. Yeah, that's great.
But these are tough, especially when someone's newly diagnosed, and the emotions of being newly diagnosed. It's I get how
hard to absorb a whole bunch of stuff. Yeah, that's for sure.
Great. Thank you very much, Dr. Eron and Dr. Halperin, and thanks to listeners for joining in. As a reminder, to view the full educational program, Contemporary Management of HIV, on the Clinical Care Options website, click on the link in the show notes. And please be sure to check back regularly for more episodes on important infectious disease topics. Thanks.